kind introduction. And today's my task is to talk about national guidelines for management of hypertension. In fact, hypertension is so a common problem for everybody of us because they are MBBS. So our MB, Bachelor of Medicine, major task of this Bachelor of Medicine is occupied by hypertension and diabetes. And it is so prevalent and common in clinical practice. So, how you would approach a patient who comes and say that my pressure is high, or a patient comes with other clinical syndrome, and it's largely contributed by hypertension. Is is helped by your undergraduate training and your reading on this various material, and then your guidelines, these national guidelines. I'm sure that you all would have read. And now, when it comes to practical use, undoubtedly you must be having some questions, queries, and practical difficulties. So, we'll see that whether we can put some light and clarification for those difficulties. Making the is it? Okay, there. Right. So this is the original script of the national guidelines. After completing this session, they say introduction to hypertension, grading and management of hypertension, diagnosis, blood pressure measurement methods, and hypertension mediated organ damage, and criteria for referral to the specialist. So yeah, I come to play, and criteria of immediate admission to these hospitals, and so that is a very relevant component of knowledge, that whether you should admit the patients, and then interventions for hypertension at primary care setting, that is you treat without referring, and how you take care of that patient's well-being. Lifestyle interventions, you have to advise. Pharmacologic interventions, you have to decide on various combinations or the single drug treatment, contraindications for various antihypertensives and its fallacies, and achieving blood pressure targets, follow-up, and targets recommended by various organizations. So this is the preventable cause of premature morbidity. In fact, it's been preventable, but though it is going unrecognized, unsurfaced, like the iceberg. Many people don't know whether they are hypertensive. It's primary hypertension known to affect out of every Sri Lankan some big number, 25% for us, but you would know that it's 1/4, but when it compared to US, it's 45% to 50%. So pretty bad. Why this was made? What's this difference? Is it that the US are more prone with genetically or otherwise? Oh, they are kind of stringent health, surveillance makes them. Yes, that's the health surveillance make them more known to this thing. Many young people fall into diabetes because of the their guidelines. They have changed from what we have put here. Hypertension is defined as clinic systolic blood pressure over 140 and the diastolic over 90, but they have changed that. So here you can see the grading. This is our guideline. Below 130, they say it's normal, but for them, US, between 120 to 130 is elevated. So their consideration is 120. So when we say that it's high normal, they call it stage 1. When we call it stage 1, it's stage 2 to them. So naturally their numbers are high. So there is another entity called isolated diastolic hypertension, where this systolic blood pressure is below 90 and over 140. The diastolic is below 90 and over 140 systolic. So the why this thing causes hypertension is such a important medical ailment which has a big impact on various people's health. I mean, when it comes to my practice, there aren't many people who have strokes or the MI. It's not the number, which the MIs or the stroke being contributed by hypertension. It's a subclinical damage which is done by underlying hypertension. It's amazing. Now, when we do a CT for some minor other complaint and they have a multi-infarct disease, when you look at their hypertension, the blood pressure, they are above 130. Though I mean, they are not really above 140. Then there are, LVH, unexplained LVH, and then we explore that's hypertension. Then the measurement of the blood pressure is normal. Then we think that our blood pressure, there must be something else. Oh, no, that is the office blood pressure. Office blood pressure is normal, but their ambulatory blood pressure is high. So the gold standard of measuring blood pressure is ambulatory blood pressure. So which catches the subclinical, but you can understand measuring blood pressure is a challenge. We'll see now when we go to the blood pressure measurement. You tend to do various errors, but when you think of catching the blood pressure, again it's more difficult because ambulatory blood pressure measurement is a bit sophisticated, not so available, and it needs kind of technical support. So the other things why it is called this thing is the organ damage. So the cardiovascular and the renal, retinal, and so on. So that we have to keep ourselves aware. So this we used to see the people in the office, but how many of we see a blood pressure measurement as they wake up in the morning? We don't have that. In fact, even if it is being done, it is this digital one. Digital meters, you all know by this time, I think, after some time it go wrong. It's the mercury one is the best, and then the other one is the spiral coil. So mercury one, even if you use it for ages, the reading is true, correct. But unfortunately, mercury is banned. So this, when you do the ambulatory blood pressure, there is one this catch of this, doing that in the morning and it's not available, and then the office, and then when it comes to ambulatory, and then how it helps is diagnosing all these things. Diabetic, autonomic neuropathy, how can you diagnose the fluctuations which is created by that, and then secondary hypertension and OSA. I think this when the word came fluctuation causes damage, not the real reading. These all people talk about the readings, but in my experience, when you have blood pressure fluctuate throughout the day, the damage is more. People are there running with high blood pressures without any damage. Even if you look into that, the whole this thing, the gamut of investigations, you don't see anything. But when it comes to fluctuation, it's how the fluctuation is created. Fluctuation is created by just the patient's normal diurnal variation of the behavior and the homeostasis. But it is man-made, doctor-made. How come it happens? You give very short-acting drugs, and its quality is poor. Patient take only once a day in the morning, then forget about the hypertension. They are very confident that they have taken the pill, but in the night nothing is left to cover the night blood pressure. The most harm is done early in the morning, during the wee hours, between 4 a.m. and then the 8 a.m. they say. So the measurement of blood pressure is, of course, all of you know it. What's the cuff size and how you put it. You put 2 fingers, and that is the tightness that you've been able to put 2 fingers inside once the cuff been applied, leave enough space there, and the size of the cuff. In fact, but the problem is whether it is available. Now, this is the standard cuff. I'm sure that the pediatricians use a small one. That's also available. This is your standard. Now, see the inflated. This much. See the width. This much. So it has to cover 2/3 of the arm, and then it has to cover the sufficient length of the arm, leaving enough space below. But when it comes to the huge one with the fat cover in the arm, do you have this? How many of you have? I'm sure that you don't have. This is my briefcase always, so that I use it, so that I know when I measure with this, the girl automatically put her one, and then that's wrong. You just put it there again, and then this you put it. The pressure is normal. When you put there, that one is high. So if you start treating for that, you do a wrong thing. Now see the size. This is for the huge people. So it is a matter of the correct appliance. Then this digital one go wrong. It's a mercury one, it's the best. Now gone out of manufacturing. Then how the person comes. Doctor, mage blood pressure balaganna puluwan. Still panting, the fellow is panting. And then ask. We also do that. But whenever we say that next time you come, with little time, you to rest. Doctor, rest kala. But they need to rest while reading and distracting their mind, at least for 10-15 minutes. You know how many of them come to you like that. When they come, they are struggling with the baby, or they are chatting, they are having a heated political argument, and they come to you and say that, yes, doctor, I am rested. So these are the wrong things happening or in all corners of your methodology. This is, of course, the various measurements of the sensitivity 54%, specificity 90. So its office one is it is not so good in catching the real hypertensives, but its specificity is good. If it is high, if it is marginal, it is not so, but if it is high, there is a fairly big a chance where that is being correct. Home blood pressure, it improves the patient's compliance. If you ask patient to maintain chart, but mind you, you don't make them hypochondriacal by giving them very unnecessary. Some people do all the time making blood pressure, but it's improve the patient so that the drug treatment is easier with them. So what is this white coat? So office blood pressure is high, but they have normal blood pressure back home. So that is the number in US is we don't know our figures, but 20 to 30%. I reckon I see about 10% to 10 to 15% if I go through my all population. So the ambulatory blood pressure is the gold standard. I told the advantages of that in various other disease entities with complication. Masked blood pressure is the opposite of the white coat. Normal home blood pressure, high. Normal office blood pressure, but high normal. Sorry, it's a home, so there's a mistake. That's 15 to 20%. Tend to have a high normal or stage 1. That is what you catch. If the fellow has home blood pressure high, your office is normal, but they are high normal blood pressure, so they are in stage 1. So that helps quite a lot, because that is doctors' anxiety white coats being eliminated, and it is a true value. So you recommend more often blood pressure measurement, and you decide on the treatment. We will discuss how you decide on the treatment later on. And then it comes to the hypertension and follow-up. Of course, we have only way of, our population you can do by making only the office measurements. Now we have the nurses, we have other healthcare workers to measure the blood pressure for you. So how much it is doing the role is those locality people only know. The hypertension, this should never be diagnosed on one clinical visit, but we do. It happens unless the blood pressure is substantially elevated. This is what I told. when the blood pressure is high beyond certain level, for instance, you would say that it reaches this level with some end organ damage, hypertension mediated organ damage, that is the term, you have fair amount of certainty that the hypertension is real. It's not the rage, anger, fighting, and then in emotional, that what it made it, and its true status. Below that, it could be anything. You can have blood pressure even close to 180 in a non-hypertensive when the emotions come. And it is there itself, I would say that not only the emotions, the stress, socio-economic stress, being awakened in the night, poor sleep, these days all contribute to hypertension. There is, in fact, there is no way that how you measure the stress so that it's not a major risk factor, but it is a major risk factor, I reckon, and you just talk to them. So this stage 2, that's how you this thing. It's now I would move to this AHA and USPSTF, that is the United States, the organization which does the values of health mediation parameters, measure and then recommend on hypertension detection and treatment, versus the ESC, that is European Society of Cardiology, and the ESH, Universal Hypertension. So this is the across the Atlantic. They have difference in catching hypertension and selecting them for treatment. So what I told is the one person's high normal is a stage 1 to the other people. US, it's stage 1, and according to the treatment. So they stage 1, they treat. They don't treat stage 1 either. When it comes to treatment, they don't treat the stage 1, but ESH, they treat, they recommend treatment, drug treatment. So they both recommend this disease modification, your modification of your lifestyle. But when it comes to the selection of treatment, there is a discrepancy. Then it comes to the Joint National Committee, very well known this body, which recommend on hypertension, and their last one on GNC 8, and then they modified it, upgraded it recently in 2021, I reckon, and then their recommendations are important because they say treatment started regardless of the age at over 140 to 90. So that is versus JNC, they didn't recommend that. Over 60 years, treat the hypertension over 150 90. But earlier they recommended over 140 90. So there was a bit of a concern, because elderly people were, when the pressure was lowered, they tend to get falls, fractures, and dizziness, disease spells. So people, there was a lot of uproar that the blood pressure treatment should not be that stringent, and then they happened to change it. Then earlier there was JNC, there was a flat rate. Then diabetes and CKD, now the current this thing is 140 90. When it comes to the European, they say it is 130 85 for the CKD. But in my experience, in CKD people, you can't come to these lower levels, and you should not, because they are GFR falls, they are perfusion of the kidney falls. Now the very early CKD, stage 1 and 2, you may be able to, then 3 and 4 and beyond, you can't treat the blood pressure. What you do is you treat the blood pressure, not overwhelming big values, which causes very urgent, imminent pulmonary edema and heart failure. So you don't have to go for the normal pressures. So these treatment choices in age, according to age groups, they say thiazides, calcium channel blocker are the choices of drugs rather than the ACE inhibitors. And the black people, you know, they can't tolerate ACE inhibitors, ARBs, because of their genetic composition. So that you need to give them these two, thiazides and calcium channel blocker. So the in CKD, ACE inhibitors are given only EGFR is over 30. When it comes to spironolactone, it is over 45. So it's crude values. You remember, you don't give spironolactone below 45. And there are this very, you will discuss whether you to, start combined therapy or the single drug therapy. So the number one is the lifestyle modification, and then the number two is single drug and build up the dose. Then the number three is dual antihypertensives to start with. Then the combine 3 or 4 drugs where it comes to resistant hypertension. Beta blockers are no longer recommended in elderly because it doesn't help in their main illness related to hypertension, that is stroke. So it is no longer recommended. That's right. Okay. Younger patients below 65, diastolic is more important than in the elderly. So this, you might wonder why there are two values being taken, and this one is systolic. And in fact, the patients also ask. So when it comes to systolic blood pressure, the arterial stiffness play a major role in bringing it up. But the diastolic, that the arterial wall come to a major role? No, it is the cardiac output versus the blood volume. So the blood volume is determined by the salt and the oncotic pressure, but the cardiac output again contributes. So it's the pulse pressure you call, and that is then the mean blood pressure. These are the other entities where you use it. So there are 3 entities: pulse pressure, mean blood pressure, and the central aortic blood pressure. To overcome and get more light on the blood pressure values, and it's not the scope of this lecture, so I don't talk about it. Then when it comes to the this thing elderly, I told that it is the isolated systolic. You know why the systolic is high and the diastolic is should be kept at below 90. That is their arterial wall thickness and the arteriosclerosis. In young people, it's the lifestyle modification which is very important, and it has you have a chance of reversing it. But in elderly, lifestyle modification, you don't have a big chance of modifying things. You have to treat it. Otherwise, the patient end up in stroke. So the blood pressure recommendations you can go through, and various suggestions being made. At last annually, repeat last. These are not so important. Why? It's the individual patients you treat. In my this thing, I don't remember these suggestions. I decide as a clinician. You are also supposed to do that. You go through the individual patient, his or her the blood pressure, then the personality and the socio-economic class, and then their attitude and their comorbid conditions and the hypertension mediated end organ damage. So those are the things recommend or suggest you to how often you must see. So these guidelines are flat in that sense. Right, okay. So I just mentioned during my introduction that it causes such a wide array of damage, but you might not remember this peripheral arteries, PVD. PVD is a huge disease entity where go undetected unless the patient comes with claudication or a gangrenous foot. But it need to be diagnosed pretty early. So it is your kind of application and then your clinical examination skills diagnose that before that where it is treatable. Likely the retina is difficult, and now you have to refer to eye surgeon to diagnose it unless you are very good in looking at the retina. So I told you this end organ damage. Here they say long-standing hypertension, it's more common than severe hypertension. We see patients walk around with 200, 220 systolic blood pressure. Yeah, so they become very keen to see that whether they have got the damage, but hardly any. But some people who have 160, but the end organ damage or the hypertension media damage is already happened. So it's the long-standingness and the fluctuation, which is in the half-hearted treatment, which causes this. So you treat, when you get infection, don't treat the infection with 6 capsules of augmentin. You treat the correct dose and then correct length. So the minimum should be more than 3 days. So if the microbiologist here would agree, hypertension you treat with the proper drug which covers the whole day, day-night, and then treat it with a lot of compatible with the patient's lifestyle and other comorbid illnesses. So needless to say that you treat early, you prevent. This is why the target's being made lower. But the patients come and say, "Ani mage kidney එක damaged." දැන් මොකද කරන්නේ? පරණ තත්ත්වයට ගේන්න බැරිද? I'm sure these questions are so familiar to you. So one thing is you have to catch it and then treat it. So this, our community people do a good job in, picking them up with all the, difficulties in the visiting them and doing the office blood pressure. But they send the patients to the specialist. Then it's irreversible at times. Reverse is a bit difficult in certain people. Now, for instance, left ventricular hypertrophy. How much you can reverse? Creatinine is elevated. How much you can reverse? But where is it reversible? That's the urine microalbumin. Urine microalbumin appears the far ahead than the irreversible damage happens. But how many people do that? It is an indicator of endothelial dysfunction, whether it is created by diabetes or hypertension. So do that. Then when it is elevated, you rule out any infections or stones or any other aseptic conditions which contribute to that, the proteinuria. Then if it is elevated, unexplained, you watch it. Then treat it. How you treat it, I'll discuss when treatment comes, and then you prevent the creatinine start going up. But how we catch is when the creatinine is up 1.2, 1.3, 1.6, and we don't have an answer to that poor patient. So various end organs, the brain, how the nervous system is affected, but it's out of that dementia and memory impairment is one of the disabling conditions. Stroke and TIAs and MI, but dementia, it goes unrecognized unless the daughter or somebody comes at the wife and tell that this fellow is we are talking very absurd things and behaving awkward. Then catch it. When there's a personality change, suspect it. So the brain imaging, of course, is very, very sad, and these days we see many periventricular and multiple infarcts, which has done devastating effects on the brain. But the patient is completely unaware and asymptomatic. So the heart, of course, the things how it get affected. And I again emphasize this intermittent claudication is one that is. The aortic dissection, of course, in high blood pressures and when the arm difference in blood pressure difference in both arms. And then this coarctation of the aorta when there is the blood pressure difference in not only the both arms, the arm and the leg. But it reminds me again how much of the end organ damage can be diagnosed other than the microalbumin, that is endothelial, how the arterial wall, the intima and the media thickness. So arterial, the measurement of the intima versus the media, arterial wall thickness. So these ratios are more sensitive than most of our investigations. So it's been there, the arm, leg, this thing is there. So this index is below this 0.9 is the prior investigation findings of the organ damage, and the suggestions for further interventions are being made. Likewise, I'm the same as the LVH, where our ECG depicts it, or the consultant cardiologist write it through the echo. And then eyes, of course, our eye surgeons help us quite a lot. So then it comes that whether you should send all the patients to the specialist. No. There are patients who walk around and come with 180, 200, but they are quite okay, physically fit, not panting. And what are you supposed to do in the clinic? You must start an antihypertensive drug, long-acting antihypertensive drug. Amlodipine is a good choice for the elderly. ACE inhibitor is a good choice for the young. And then what advice you give? You must get yourself thoroughly investigated by a cardiologist or a consultant physician. Do you say that rush to the hospital immediately? No. You do say that your pressure is gone, you are going to get burst? No. Then it causes further up of the jack up of the blood pressure, because they get so anxious. Never do that. But if the patient is breathless, patient has edema, patient is really prostrated, you tell them you must get admitted. I'm afraid you need pretty close attention quite early, and your lungs are not good, your heart is pounding, your second heart sound is so loud. You don't tell to the patient, but you based on that examination, and you tell. So it is a counseling, and then giving the correct advice is the most important. Likewise, you see the ECG, there is LVH and a T inversion in the V6. So you don't tell the patient you have got serious ECG damage, your heart is going to get finished. මේක ලොකු change එකක් තියෙනවා. දැම්ම යන්න. ඔයාගේ නහර block කියලා. So this is the nahara block ECG in a young fellow who didn't have any nahara block, and this is a elevated state. So there's this, very dramatic changes created by some ST depression and T inversion in the lateral leads, and the L1 is not unstable angina or MI. So it is created by the left ventricular stress. So all of you should be very thoroughly aware of that, and then don't scare the patient. Poor fellows come running and ranting and do various things to see the doctor immediately, and it's not that necessary. You examine the lung, the pulse rate, second heart sound, loudness, and take a ECG. These are due to hypertension. Already your heart has got some changes like that. So it's specialist referral needs when you suspect this white coat hypertension, masked hypertension, and so on. Resistant hypertension, of course, is a very clear indication. We'll come to the definition later. This, of course, is they have given some this thing, we have discussed it, and so how do I get reversed? Reversal එකට පොඩ්ඩක් කරන්න. මට වැරදුනා. මේක reverse යන්න. මේකෙන් පුළුවන් reverse. හරි. ඒක තමයි. So the resistant hypertension is defined as blood pressure remain elevated over 140/90, where you have used already 3 drugs with adequate counseling and lifestyle modification, and out of these 3, one happens to be a thiazide diuretic. So when it comes, the resistant hypertension needs really touched by the specialist. The other one is how you think of secondary hypertension. All the people are not having secondary hypertension. It's so low, the number, 5 to 10% perhaps. So what are the secondary, these things are the adrenal damage due to Cone syndrome, or the adrenal tumors, and then renal tumors, or renal obstruction and other obstructive uropathy, and then the coarctation of the aorta and the renal artery stenosis. So these are the secondary ones, the common, other than various biochemical changes and the enzymologies that which causes very rare secondary hypertensions, which is related to really the other hormone changes related to the adrenal gland. So criteria for immediate admission is over 180, 120 with evidence of end organ damage. If the patient is clinically bad, you need to admit. There is evidence of left ventricular failure, undue breathlessness, and then edema and the low urine output. So evidence of AKI or impending stroke or impending MI. Those are the main three presentations. And if you suspect dissection of the aorta, you need to admit. And the treatment is in the emergency department. So the primary care setting, the interventions they make, the suggestions, and it is what they say is over 140, 90. You got to treat, but the real expansion according to the world bodies, it's over 130, 80 that you need to come out with your all the interventions. That is mainly the lifestyle intervention and the disease modification by stress management, cope up with the stress, and then once you have done that, you can go on how they have mentioned here. Drug treatment starts after 3 months. That's coming from the guidelines, international guidelines, very clearly. They are also reflecting that. Once you have been unable to reduce the blood pressure to 128 in young, why they suggest you treat drug treatment. But these young people, why you need to treat them the high normal. There is a study called cardiac study, which they have done in between 80 and 55 years people, and where the people are very, many people have 40 to 76% of the people have hypertension, and some as they followed up, they are getting some secondary changes. So, but when it comes to this catching these fellows and treating, it's a huge medical cost and difficult. So this cardiac study has given the light on that, but when it comes to implementing that in countries like us, it's very difficult. Grade 2 hypertension, of course, you look for the cardiovascular end organ damage and the diabetes, CKD, and this estimated cardiovascular risk is used. Now, when it comes to grade 1, the young, not the grade 1, the high normal in European or the American setting, the main the intervention of yours is go for the cardiovascular risk. They don't have end organ damage. So you have the cardiovascular risk assessment charts. If their risk is below 10%, the lifestyle modification going on for 6 months or even 1 year is indicated. There's no these things warranted. So that is how you manage it. So, but it is different when the risk is more. It's 10 and 20. Of course, you need more closer supervision, individual sort of assessment. But if it is more than 20, of course, you have to take a very close look up, and then you might go and start treatment within 3 months of lifestyle intervention in high normal. So you can prevent end organ damage. This the two studies are the cardia and the MESA multicenter study of atherosclerotic sclerosis. So the MESA study is again revealing that it's very essential you catch these diagnoses early. So the lifestyle interventions, of course, you can read this: food, water, salt, and all these things. You know, I'm pretty sure that you are good in doing that, giving advices. I'm not going to repeat those. Alcohol use, of course, you must be struggling. How much you advise, they go on increasing the alcohol take. Saying that, answer, doctor, there's suggestion that wine is good. There's a J curve. They know everything, and they say that why should I? Even the Queen Elizabeth took shot of whiskey. So I also take. ඇත්තටම doctor effective නැද්ද? Yes, effective. If you ask from our colleagues, also say that. Our consultant colleagues also will tell that it's effective. But but when it comes to the addiction, we all control ourselves. We all drink and we are control, but not the ordinary people. They get the kind of boost in this kind of well-being, and then they go on taking that. So these other months, amount of work, walking, there's a specification. Be mindful that it's just not 5 minutes, just hit again, just that is not that type of exercise. So this is what I told about this the low risk adult people, where the atherosclerotic cardiovascular disease risk is less than 10. You go on treating modifying the risk factors, but stage 1 according to the Americans. This is according to Americans, not the Europeans. You still go on treating the lifestyle modification with non-pharmacologic management. After 3-6 months, they change it into drug treatment. This thing doesn't mention that, right? So, what are the conditions that there's where you got to treat patients immediately? So, one is that when you see the vital organs are affected. So, heart is in failure, kidney is in AKI, there is a possibility of impending stroke, there is a possibility of the other one is arterial dissection. The others, there is no indication, not in the guidelines either, and when you start processing early on or in elderly, you tend to give them a postural hypotension. The patient falls, patient is dizzy, they are unable to get down and stand up, they fall. So I never give processing unless there is as a fourth line drug where the renal failure matters. That is the maximum dose I give is 1 milligram BD. Whenever I give 2 milligram BD, the patient comes with postural hypotension. HCT, we started those days by giving 100. We thought that is a good antihypertensive. Is it? No. Beyond 50 milligram, it has no antihypertensive effect to reckon with. Substantive antihypertensive effect beyond 50. It causes very bad electrolyte change, sodium and potassium. They commit hypokalemia, fatal hypokalemia. And when it comes to the other impotence and some diabetic tendency, that is a notorious drug to be given, HCT. That is why we don't like this combination where the HCT, thiazide, one of the losartan H, then the telmisartan H. But Westerners know that, they give only 12.5. That's true. I mean, it hardly has any impact. But when it comes to the importance of giving the diuretic, what is the drug of choice for the diuretic? That is the long acting. What the Westerners give are bendrofluothiazide. When I was in UK, they give bendrofluothiazide. That is 2.5 milligram in the morning. It's very potent, and equally that's very long acting. Not like HCT. And here what we have instead of that is natric acid, right? So what is called what is it? EMPA? No, it's a natric acid, isn't it? The long-acting low SSR, endopamine. So that's long acting. And when it is made slow release, like Lovasis or the other brands are there, those are very good. In fact, one of my teachers was during this thing is suggesting, can it be given in the night? Because it helps in the control the blood pressure in the wee hours and the early morning. It get extended to the afternoon. So we all said that it causes diuresis and never given in the night. But he says there was no such bad effect. None of my patients complained, but none of us agreed. And no world bodies recommend it to given in the night. You give it in the morning. That's a very nice drug to be given in the morning, long-acting diuretic. What is most important drug, which is no need to be given, I'll come to that. But how am I going now? It's working? Sorry. So this is what I just talked about without going to the slides. Slides are messy and then these are guidelines ones, one of my ones. But when it comes to pregnancy, of course we have to use labetalol, that's the drug of choice, as a beta blocker. And then methyl-dopa, the good old drug still I use, and it's very nice drug still for the pregnancy. So the stepwise approach, they have given this messy slide. I don't want you to read it now, but this is we have largely discussed. These are the things that I talked with during the absence of power. When it comes to the AC inhibitors, of course, other than the renal failure, this is the bilateral renal artery stenosis. You all know that. I don't have to tell. High risk of hypercalcemia, pregnancy you avoid. These are nothing big and new, asthma and fixing. Blood pressure targets we largely have to hold. I just don't have to talk about that. Now this over 80 years. So there are for us the elderly are over 60, but the Westerners it's over 85. 60 is young, so that they don't talk that they view the stringent blood pressure treatments for them, and like what we talk. But the guidelines have made that little allowance is made. I told you that their target over 80 should be 150 systole. You must not bring it below 150, and diastolic 90. And they say if the patient is fit, not the chronologically, but the physically, and other ailments, comorbid conditions warrant that helps you, and doesn't give you big contraindications, you go for the lower target, that's 140, no harm. So there are very fit people in Western, not only Western, in our country, where you can go for lower targets. So when it comes to these things that I told in advance, how you treat these patients with heart failure. Heart failure, of course, like kidney failure, I told that there is no way that you can reduce the blood pressure very drastically. You end up with a rising creatinine. Heart failure, of course, you have to bring the blood pressure 130 and 80 below this thing to improve the heart ejection fraction. And our consultant cardiologist must be knowing that that is the way one of the most helpful thing is to reduce the blood pressure to that level in order to prevent further pulmonary edema accumulating and the heart get dilated. But when it comes to the lowering blood pressure, there is a risk. When the heart failure fail to respond to your drugs, we encounter the blood pressure can drastically go down when there is comorbid conditions and atherosclerotic disease. So that you have to be very careful. You keep the blood pressure around 140 rather than ending up with a disaster. So that's how we manage our emergencies. And this heart failure, when it comes to the heart failure with reduced ejection fraction, of course you know, but when it comes to the preserved ejection fraction, the things are pretty unclear all these days. Whether how the treatment of antihypertensives help in reducing the risk of end organ damage due to reduced the preserved ejection fraction. Of course, luckily, recently the trials came on empagliflozin, that is the drug of choice now to maintain the blood pressure in reduced ejection fraction, controlled blood pressure, other than the AC inhibitors. Proteinuria, yes, of course, I told that how you, I mean, it is a thing that you must do very early, and then, in all the hypertensives, by eliminating the fact that there is, renal, reasons, sepsis and aseptic pyracosine like tumors and the prostatism and foreign bodies and things so on, you diagnose it, you treat it. How you treat? There is the spironolactone, that is aldosterone blockers. So these are the newer stuff which spironolactone came through very handy with various trials recently, and we used it to much of a good effect. That is one of the best combinations of the third line drug than thiazide combined with thiazide, ARB and calcium channel blocker. Even before starting some calcium channel blocker with AC inhibitor plus spironolactone, you might tell that it both cause hyperkalemia. No, it's not. It doesn't cause that much of hyperkalemia. But you have to, of course, look for hyperkalemia very energetically. But it is much safer with calcium channel blocker and spironolactone in elderly. That is the best combination. And when it comes to renal failure, of course, the hyperkalemia is the constraint. Now they have developed various newer drugs. Those are non-steroidal mineralocorticoid inhibitors, right? Spironolactone, you know that it's a hormonal one. That is why it causes gynecomastia. That is why it causes change of the kind of mood and things. So you got to avoid these things, and if you are able to use in renal failure, that would have been fantastic, where the spinal hyperkalemia is avoided. Now they have found a solution, and it will come to effect. Now what we had was spironolactone and epinol. Now we have we'll get finerenone and hexaxerinone, right? These are the newer ones. This now the superiority of this spironolactone was showed by pathway 2 trial, but later on this Fidelio DKD trial, now they show that it has a very marked effect on diabetics and renal failures, where it can be safely used without bothering about the hyperkalemia. So that is a very handy one. Now, what are the other options of treating novel therapies of treating hypertension? Is one. There are so many array of treatments, but what would be very sophisticated treatment, which is shown by the Radiance and Simplicity trials, that ultrasound ablation of the renal nerves. So renal nerve denervation, ultrasound destruction. So that is shown in Radiance 2, and then Simplicity HTN 3 and 4, and it goes on. I mean, now in phase 3 trials, which will come into in sophisticated, and must be already in use in other countries, where this you use without any drug and reduce the blood pressure without with using drugs in affordable lower doses, and still controlling very previously uncontrolled resistant hypertension. So to come to the end of this thing with the important message. So this spiral hypertension trial, OnMed trial, has shown that 5 mm reduction in systolic blood pressure has a meaning. So mean systolic blood pressure, right? When it comes to the real blood pressure, it could be about 10, 15. And it reduces the stroke mortality by 10%, and it reduces ischemic event by 7%. So when you get a hypertensive patient in your office with a alarming alarms ringing in your mind, and how much you should do the patient and how much you contribute to the well-being of the patient, this is the answer. You don't have to bring it to 120, 80. Don't think of that. You do it, give some long-acting drug and assure the patient, and give the lifestyle modification advice, including the salt and increase water, reduce salt and so on, reduce the stress, and you have done the job. Even you are unable to meet the consultant. So you give a leisurely an appointment to the consultant if it is needed to this thing. You have done your job. So you don't have to rush giving an appointment and alarming the patient very badly, which causes a panic reaction. So that is my message. Don't rush. You reduce the blood pressure sufficiently and eliminate the highest risk. In the ward, when it comes to our juniors, they are pretty well aware of that. If you reduce the blood pressure drastically, what happens is watershed infarctions. If you reduce correct the salt, reduce salt, you correct it, you get hyposmolar damage to the osmotic damage to the brain stem initially and the whole brain. Patient's condition is become pretty bad as the time to come. Patient doesn't recover. You know it. Pressure also the same. And you reduce it during the first day 10%. Second day 25%. By 48 hours, beyond 48 hours, 72 hours and beyond, you bring according to the age matched guideline recommendations to the as low as what is recommended for the age and the comorbid conditions. So that is my take home message. You do that. You don't have to rush. Thank you. So if you have any questions, I'm happy to answer if I happen to know it. And so I think I gave my practical points to you. Are there any questions? So you might ask that why the combined pill, how it plays a role. In other countries, people go to Middle East and bring combined pill. What we have is only the HCT as a combination. We don't have others, and does it help? So the combined pill, of course, there's advantage of patients' compliance. Patients don't take. Westerners, of course, have come to research, have given evidence that they don't take. They forget the other pill. They don't like too many pills. So that combined pill ensures this thing. But combined pill will not give you that nighttime control. It doesn't answer the question, the problem that what I mentioned. So besides that, as time goes, unless the patient comes back, the patient go on continuing the unnecessary drug, which is combined. All are dynamic. There is no static patient who need the same pill for the whole rest of their life. So those are the other treatment selection size. I think that's it.
Good afternoon. It's my privilege to have here to deliver, extend my gratitude on behalf of Mahatma Clinical Society, sir. It was an interesting